Hey everybody, welcome to another Minority Mental Health webinar. I am Dr. Armstrong here with Dr. Joe, who is going to be presenting to us on HIV and mental health today. We're very excited to have you all for our final live webinar, which will offer one CEU, which you will get after the session if you complete our post survey. We'll be talking with Dr. Joe. I'll be monitoring the Q&A, so please post your questions in the Q&A feature or in the chat. I'll be monitoring both so that we can have a very engaged conversation about HIV and mental health. And with that, I'm going to cede the floor to Dr. Joe.
All right. Well, good afternoon, everyone. I'm excited to be with you all. I'm going to share my screen so you can see the PowerPoint I've got going for today. Awesome. So today I am going to speak about HIV with an emphasis on stigma. And my title for our presentation is It is Better to Speak, Using Our Voices to End HIV Stigma. And this is a topic that's very near and dear to my heart. I'm a faculty member at the University of Central Florida, and part of my role there, of course, is teaching, but I also do research as it relates to HIV, specifically with the focus on mental health, counselor ed, education, and preparing our counseling students to serve clients who are living with HIV, as well as looking at the mental health implications and what things we can do as mental health professionals to address the concerns that are related to this particular illness. This has great relevance as we are in the month of July with minority mental health, because we know that HIV does disproportionately affect people of color. And we'll talk a little bit about that as well. And we know that when mental health and illnesses of various kinds intersect for people of color, that it presents a unique experience. And so there are some things that we can do, that we can use our voices to address so that we can support people who are living with HIV. So just to give us some context and share where I got the inspiration for the title from, I want to share a quote from Audre Lorde. When we speak, we are afraid our words will not be heard or welcomed, but when we are silent, we are still afraid. So it is better to speak. And I share this quote with you all to kind of set the stage for what we're going to talk about, because Audre Lorde, as a Black woman, as a feminist, as a queer Black woman, knew very well the experience of being at the intersection of multiple marginalized experiences. And she knew what silence meant for a person in that vulnerable position, and spoke and wrote extensively about the importance of using voice, not remaining silent, and speaking out about those experiences. And I think that this quote is really important when we think about HIV as it relates to people of color, because there is so much silence that surrounds HIV, so much silence that results from the stigma associated with this particular illness. And if we remain silent about that, then there's going to be no end to that stigma and no relief for people who are experiencing the adverse effects of HIV and HIV stigma. So it is better for us all to speak. It's better for our clients to speak. It's better for us as helpers to speak as well. And so that will be really the theme that runs throughout this webinar, is this idea of speak. How do we use our voices to bring an end to the stigma and to really address the concerns related to HIV? So what we'll get into today, to give some kind of structure to the webinar, we'll start by talking about HIV prevalence, looking specifically at the state of Arkansas. I've got a great resource that I'll share with you all that shows a map of the state and provides some statistics around that so you get a sense of what's happening in your state. We'll also talk about the health disparities that come out of that and what that means for people of color as it relates to mental health. We'll talk about the impact of stigma and how HIV stigma impacts individuals in various ways. And then we'll talk specifically about some things that we can do, what we can do to address HIV and really support the mental health and wellness of people who are affected by HIV. So to start with, I want to share these two maps, and we'll look a little bit more specifically about details for Arkansas in just a moment. Whenever I do presentations on HIV, I love to pull up the AIDS View information. This is a great resource that provides statistics, demographics, visuals about HIV as it affects various communities across the United States. So on the left, we see a map of the United States that demonstrates the HIV prevalence in the country. Prevalence refers to how many people are living with HIV currently. And the areas that are darkest on this map are the areas where HIV prevalence is the highest. And so we notice just automatically by looking at this map that there are areas that are really affected by HIV more so than others. We see specifically the southern states of the country, especially those in the southeast, and the state where I currently reside, the state of Florida, very, very dark. We also see some parts in New York, some parts of lower Southern California as well. And then some various places across the country where there are metropolitan areas where HIV rates are highest in those areas. If we look at the map on the right, we see the state of Arkansas. So the map on the left, you can see where Arkansas is. It kind of blends in with some of the other states. So to zoom in, we can look on the map on the right. And I'm not familiar with all of the geography of the state of Arkansas, but you will be able to find your city, your region in the state. And remember, the darkest areas are the areas where HIV is most prevalent. Now, you may have some understanding of kind of what's going on in your state and why those rates might be different. But it's really important to kind of think geographically where an illness is impacting residents in a particular place, and what do we know about those individuals in those areas. So to get a little bit more detail about what's going on in Arkansas, I'm going to share with you all some information from this particular website that focuses on the state of Arkansas. So this again is the ASView website. And I love this website because it's interactive. You can get lots of information and you can literally go down a rabbit hole. You can look at information by state. You can also look at information by city. So here is the data for the state of Arkansas. And again, we see the map that we were just looking at a moment ago. If we scroll down a bit, we'll see some information about some of the statistics about who is affected by HIV in the state of Arkansas. And so when we look at the HIV prevalence rates, what we notice first is that males are more affected by HIV than females. And that is the case not just in Arkansas, but really across the country. And I'll talk a little bit more about that in a moment. We also can look at the HIV prevalence rates by race and ethnicity. And so here are the three racial categories and ethnic categories that are most affected in the state of Arkansas. So Black, white, and Hispanic or Latinx communities, the percentages are listed there. Now, what's important to note is that these are the percentages for HIV prevalence, and we've also got to take into consideration what the racial breakdown of the population is in the state. So we'll take a look at that in a moment as well. We can also see by age categories where the prevalence rates are higher or lower. Now, HIV incidence refers to new diagnoses of HIV, and so that's what these numbers in blue here show us. And again, we see that males are more affected by HIV than females in terms of being newly diagnosed. We also see some shifts in the numbers based on race and ethnicity. So when we were looking at prevalence, and according to how many people are currently living with HIV, for Black residents of Arkansas, it was at 44%, but the new diagnoses is up to 55.5%. So in terms of who's being newly diagnosed with HIV, that's happening in the Black community. We also see an uptick in the number or the percentage for the Hispanic Latinx community. And again, we've got to think about the population there and what that might mean. We also see here that the age group that is most newly diagnosed is that 25 to 34 age group. And really, if we look at 13 to 34, which is often what individuals look at in terms of newly diagnosed, that age group is overwhelmingly represented in the cases of newly diagnosed. So we're talking about young people under the age of 35. We're talking largely Black residents in Arkansas and largely males. If we scroll down a little bit more, I'm going to skip some of these things, but feel free to kind of look back them on your own. as I mentioned before, if we think about like the demographics, we've really got to consider what the population of Arkansas means for the prevalence rates for HIV. So we've got to think about like breakdown in population across the country. We also have to think about in the state of Arkansas, like what that looks like. What we know across the country is that there is a great disparity between the representation in the population for various racial and ethnic groups and those that are affected by HIV. So if we look at the population, we know that 15% of the population currently are Black African Americans, but across the country, and is the case in Arkansas, we see a large representation of individuals living with HIV. So there's a disproportionate effect of this illness in communities of color. Some other things that I want to point out when we look at related to those kind of disparities, we see, and this happens, these are trends that we see across the country, that Black males are many times more likely to be diagnosed with HIV, the same thing for Black females, as well as Hispanic and Latinx men and women. And so we have to take these discrepancies into case when we're thinking about how HIV is impacting communities, especially communities of color. Some other important information is to think about how people are contracting HIV. So as I mentioned earlier, males are overwhelmingly affected by HIV in terms of both prevalence and incidence. And most of that transmission is from male to male contact. So HIV has historically and currently now has disproportionately impacted the gay community, and gay men have largely been affected by this illness. And we know now that Black and Latinx men are disproportionately affected by HIV across the country. And we also see those trends in Arkansas as well. So I'm sharing this information with you all because as we're talking about minority mental health, as we're thinking about how HIV connects with that, we know that communities of color are disproportionately affected. We also know, and this is something that has recently become more of a talking point, is that communities in rural areas are becoming much more affected by HIV than they have in the past. And this is really a national conversation. And we can even look at some of these maps and see some of those areas that are more rural than the others, where we're starting to see some trends, some upward trends in terms of HIV diagnosis. And so what this means is that there's an intersection between this illness, race, and ethnicity, gender, as well as geographic location. And then if we consider how socioeconomic status comes into play as well, what we have is that an illness that impacts the physical body has an effect on a person's whole mental health and wellness, because it impacts many, many very different aspects of their lives, especially if those individuals are already in multiple marginalized places in their lives. So I wanted to share that information with you, and I put the website down at the bottom and encourage you to go back to that information and just to kind of see what's going on in areas around you, to get a sense of maybe the city that you're living in Arkansas, what's happening in that particular region, to see sort of what's happening for individuals that you may come into contact with. So let's talk about what this means for individuals. So I wanted to share kind of some information about the prevalence and incidence, just to kind of give you a picture of how HIV is kind of distributed across the country and in the state of Arkansas. But if we drill down, we can think specifically about how HIV and the stigma that surrounds it impacts multiple aspects of people's lives and multiple aspects of the illness itself. So I've got to give a little bit of just a really short history, because we don't quite have the time to do an exhaustive history of HIV in the United States. But we know that in the 1980s that the illness was first identified. And actually, it's interesting because we often talk about HIV and AIDS was identified first. So acquired immune deficiency syndrome was identified, and it was a collection of illnesses that medical professionals were seeing, and they put the name AIDS on it. It wasn't until later that the virus HIV was actually identified. And it was discovered that the virus is what leads to this constellation of syndromes and what is the word I'm trying to think of? This illnesses that people were experiencing. The virus was actually identified as what was causing it. Now we know, of course, that in the 1980s, there was a great deal of fear around both HIV and AIDS because there was mystery surrounding it. Initially, there was not a lot of conversation about it. People weren't really sure kind of what this thing was. And all that people were hearing is that individuals were dying. And so there was a lot of video footage of people who were dying, and it was a death that was visually unappealing. So there were people who were physically wasting away, who had sores on their bodies. And of course, the community response to that was one that invoked fear. And so there was a lot of fear around HIV in the 1980s. And unfortunately, a lot of that fear fueled stigma and fueled ideas about the illness that really continue to this day. We can sort of see a parallel between what's kind of been happening with COVID-19 as well, that there's a lot of questions about it, there's a lot of fear surrounding it. And similar to HIV, there hasn't been great leadership about kind of what we should do and how we should address this illness. And the same happened with HIV, that there were questions about the response from the president at the time to this particular illness. And there were questions about like, what is the most appropriate way to address this particular illness? And sadly, HIV was associated with gay men, as well as people who inject drugs. And because of those experiences, there were a great deal of assumptions that were made and a lot of judgment that was made about anyone who contracted this virus. Assumptions about their morality, assumptions about kind of their right to life, assumptions about whether or not they were worthy of care. And unfortunately, although we've come a great ways in the 40 years since then, some of those ideas still remain, and they still kind of fuel experiences around HIV and decisions that people might make and experiences that people might have. There's been some research specifically on stigma related to HIV stigma in particular. And I've shared two quotes with you that really encapsulate what HIV stigma kind of is all about and what it does. An enduring condition, status, or attribute that is negatively valued by society and whose possession consequently discredits and disadvantages an individual. So we think of HIV as that enduring condition. We see what has happened to people who have lived with HIV, that they have been discredited, they have been disadvantaged. Additionally, more specifically, people targeted by HIV stigma have historically had less access to valued resources, less influence over others, and less control over their own fate than their uninfected counterparts. So again, this illness, because of its kind of early history and associations and assumptions that are made around it, impact people adversely, discredits people, disadvantages them, gives them less access and less control. What that means specifically in terms of outcomes is that mental health and wellness are impacted as people internalize that stigma and internalize messages about worth. It also impacts people's willingness to be tested, to engage in treatment, and it also fuels laws related to and thoughts about HIV criminalization. And so those are all the areas that we're going to take some time to talk about how HIV stigma impacts each one of those areas. So to kind of give us an idea about what the experience is like for someone who's living with HIV and how HIV stigma might impact that, I want to share with you what is called the HIV care continuum. The idea behind the care continuum is that an individual, once they are diagnosed with HIV, there's a process that they go through in order to be connected to care, to become engaged in care, to have access to treatment, to stay on treatment, so that ultimately they can live a full, healthy life. We know, of course, that that is possible. Many things have to happen for an individual to be able to live a full, happy life, but we know that it is possible to do that with HIV. So on this care continuum, there are a number of spots where HIV stigma can impact people and where we can sort of intervene and disrupt some of that negativity that the HIV stigma might bring to someone's experience. So for instance, on this continuum, we start with someone who's been diagnosed with HIV. So if someone goes in for testing, they receive a reactive test to the HIV test. The idea is that they should be automatically linked to care. So they should be connected to a physician who is an expert in this area that can provide them with the medical care that they deserve. So they're linked to care. They actually receive HIV medical care, which means that they get a full panel of blood work, that they get a medication regimen that they can be adherent to, and they're engaged in care for themselves in a medical sense. There's also a need to retain them into care so that they continue to be adherent to their medication, so that ultimately they can get to the point of viral suppression, which means that the HIV virus that is in their body is the lowest that it can be, and they can live a long, happy life if that happens. That's kind of the goal for anyone who is living with HIV. However, we know that stigma can affect every piece along that way. Stigma can affect us from the very beginning. So if we're talking about people being diagnosed with HIV, that would mean that they would need to get tested. And unfortunately, due to HIV stigma, many people avoid testing, or they inconsistently get tested. The CDC recommends that everyone get tested, and people who are sexually active get tested about every 6 months. And for individuals who may be at greater risk for HIV, be tested every 3 months. But due to stigma, we know that people's willingness to get tested is diminished. We also know that people sometimes will kind of disguise their interest in getting tested for HIV because they may not want people to know that they're concerned about their status, or they might think that people will assume that they're HIV positive just because they want to get a test. So unfortunately, due to stigma, people avoid it and don't do it. They may also avoid prevention efforts due to stigma as well, and may not engage in the prevention that they could engage in order to reduce the likelihood of contracting HIV. We also know that for individuals who are linked in care and who are receiving medical care, that stigma can impact their engagement in care. So if individuals go to a healthcare professional and they experience a negative reaction from individuals who are in that space, if they don't feel welcome, if they don't feel comfortable, they might be disengaged from their own medical care. We know that that happens with mental health as well. If individuals don't feel accepted in a particular space, they're less likely to come back. And that happens often with HIV. If people experience negative comments, negative language, and negative interaction with a medical professional, they may drop out of care because of that. We also know that stigma impacts adherence to treatment. So if an individual has a medication regimen and they're concerned about other people finding out about their medication regimen, that may affect their adherence to it. So they may not take their medication as prescribed when they should take it as prescribed because they're concerned about other people seeing it. And those other people could be family members or people with whom they live. It could be people with whom they work, anyone who might be in their circle. And so we know that due to that stigma, people may be less likely to adhere. And all of that means that there is a decreased likelihood of viral suppression, that people would be able to live a long, healthy life because stigma may disrupt this HIV care continuum. We also know that HIV specifically affects mental health. So we know, of course, as mental health professionals, that the physical and the mental really overlap in lots of ways. If we think from a holistic perspective, we know that there's a mind-body connection. And so if an individual is living with HIV, they're dealing not only with the physical effects of that illness, but they're dealing with a unique psychology that is related to HIV. That psychology can bring in thoughts of lower self-esteem, thoughts of depression, suicidal ideation. It might cause disconnection or avoidance of people that they have been connected to in the past. There may be thoughts of self-blame and self-worth. And then there are concerns about substance use and abuse as well. And those overlap. So if an individual was already dealing with a substance use issue and they're also diagnosed with HIV, each of those can kind of exacerbate each other. So there are several concerns related to mental health for individuals who are living with HIV, because the illness itself brings in all of these multiple mental health concerns. We also know that for people of color, for women, for individuals who are non-binary and transgender, that the stigma that they might experience related to those identities intersects with HIV stigma and makes their life even that more challenging. So if we think about, for instance, Black men who may identify as gay or bisexual, they are dealing with racism, they're dealing with homophobia as well. And then on top of that, they're dealing about concerns related with HIV stigma. And that might affect, if they're not living with HIV, that might affect their willingness to be tested, their willingness to engage in prevention efforts. And if they're living with HIV, it can affect their livelihood, their well-being, because they're dealing with multiple layers of stigma and oppression because of their social location. It's important to note that that there are a number of protective factors that can be really helpful for people who are living with HIV. And a lot of those deal with connection. Social support, having a social network of people can be a protective factor when individuals are dealing with the psychological effects of HIV, as well as the stigma related to the illness or related to their other experiences of social oppression. That social support, of course, can be challenging because it may not be, for instance, family support. Relationships with family might be challenging for some individuals. So that social support may be friends, it might be family of choice, but being connected to other people we know is critical for individuals who are living with HIV. We also know, of course, that mental health care is as important as medical care. So individuals who are living with HIV, we want them to be linked and connected to a physician. We also want them to be linked and connected to a mental health care professional. This is why integrated care is so critical, because for this illness in particular, both the body and the mind have to be cared for an individual to really live a full life. And lastly, we know that HIV affects HIV criminalization. And this might be something that you have kind of less knowledge about, but it is an element of this concern that is really important and something that we really need to kind of use our voices to speak about. Since the 1980s and 1990s, when HIV and AIDS were really a concern across the country, several states enacted laws that addressed HIV criminalization, specifically related to the transmission or assumption of transmission or attempt to transmit HIV from one person to another. HIV is, in many cases, the only illness that is criminalized in this way. And in many states, there are specific laws that identify HIV as a criminal offense, right? Not just having the illness, but there are laws about interactions with other people that could possibly transmit HIV. Now, what's a major concern about many of these laws is that some of them criminalize behaviors that are not likely to transmit HIV. So for instance, in some cases, there are laws that would criminalize a person who's living with HIV spitting on another person. Now, we all know, of course, spitting on another person is a terrible thing to do. However, it's not something that is likely to transmit HIV. However, in some states, that's a criminal offense that a person can be prosecuted for and imprisoned for. That doesn't even really make sense, because there's not a threat to another person, because spitting on someone is just not how HIV is transmitted. The other concerns that exist with some of the laws is that they have what are called sentence enhancements. So if an individual commits one crime, if they are HIV positive, there is an enhancement on their sentence. So their sentence might be longer by virtue of the fact that they're living with HIV. Now, this of course does not mean that the original offense that they commit is not a problem. It very likely is a problem. But what is a concern with those laws is that it additionally criminalizes individuals living with HIV. And the message that that sends is that people living with HIV are dangerous and should be feared. What we know in reality is that people who are living with HIV, who know their status, are not intentionally trying to transmit HIV to other people. And that's kind of the assumption of many of these laws that goes back again to the 1980s when there was a lot of fear surrounding this particular illness. And those who were living with the illness were characterized in a particular way where they were life-threatening to other people. That's kind of what the ideas that undergird many of these laws, and those are very problematic. And so HIV stigma kind of fuels these laws, but then the laws themselves also fuel HIV stigma. And what it will mean is that people either won't get tested, they will have difficulty talking about their status because they will assume that other people will kind of respond to them in a negative way, and there'll be sort of a fear response, that they'll be characterized as predators or assumed to be harmful to other people, where they're really just trying to kind of live their lives. So what we see with the HIV criminalization laws is kind of the worst of what HIV stigma can do, because again, it characterizes people in a particular way. And if you're living with HIV and these laws exist, and the ideas around these laws really are pervasive in a community, we know that people can internalize that. That affects behaviors, that affects well-being, that affects mental health. If you look closely on the map, you can see where Arkansas sits on there. And so Arkansas has got like colored stripes as well as this little yellow dot there. And so what the colored stripes mean is that it's one of the states with specific HIV laws. And it's a state that, in addition to specific HIV laws, it has also prosecuted people who are living with HIV under non-specific HIV laws. So in some states, they don't have an HIV specific law, but they still criminalize people who are living with HIV under general laws within the state. And that's the case for Arkansas. So Arkansas does both. In addition to that, the little yellow circle means that that's one of the states that requires an individual who is prosecuted under their laws to register as a sex offender. Again, it's associating an illness with an offense that may or may not be legitimate. And again, that fuels the stigma that surrounds this particular illness. So I guess I'll pause here to see if there are any questions. Do we have any questions before we go forward?
So we haven't had any questions yet, but if anybody would like to post a question in the Q&A or even raise your hand, I can unmute you and we can have a little bit of conversation with Dr. Joe. Oh, we have a question. All right, Patty, I am going to allow you to talk and you're unmuted.
So I just wanted quickly to get some clarification. So are you saying that in the state of Arkansas, someone who has HIV is actually having to also register as a sex offender?
So not for just having HIV. So, and I'm not 100% sure of what the specific law in Arkansas says, but in many cases, what these laws will say is that if an individual who's living with HIV engages in sexual activity with another person, the law may criminalize that behavior. There also might be a law related to disclosure. So if a person engages in sexual activity with another person, does not disclose their status, then that can be criminalized. So that is the behavior, not just the status, but if they engage in sex with another person and they're HIV positive, that behavior could be criminalized. What's concerning about this is that even if a person, in some cases, for some of these states, that even if they disclose their status, and have consensual sex with another person, that behavior could still be criminalized, although they have disclosed and the sex was consensual. And in that case, that could be a person who would have to then register as a sex offender if they're prosecuted under that particular law. Again, I'm not 100% sure what the specifics are of Arkansas's laws, but that the visual that I showed you, I'm going to go back to that actually. So this picture here is from the Center for HIV Law and Policy, and they have all the details on every law in all of the states that are related to HIV. Did that clear up your question?
Yeah, it did. And it's actually very concerning to me because I am a certified sexual offense treatment provider, specifically for adolescents. And so that is something I will be looking into further. So I appreciate you bringing that to my attention. Thank you.
Awesome. Great. Yes, you're welcome. Yeah, it is a concern. And there's a movement in some states across the country to address these laws. And in some cases, the laws have been removed from the books. In other cases, they've been changed and modernized so that they actually reflect current medical knowledge about HIV, because some of them, again, were criminalizing behaviors that cannot transmit HIV and should not be written into law. So there are some efforts to address some of those laws. Any other questions?
I'm not seeing any questions just yet or any hands.
Awesome. Awesome. Well, we'll keep trucking. So those are the concerns related to HIV and stigma, related to will people get tested? Will people engage in treatment? Will they be adherent to treatment? What would their mental health and wellness be like? And as we started this thing, we talked about the importance of speaking and using our voices to address it. So what I want to share now are some things that we specifically can do to use our voices to address the HIV stigma and support clients who are being affected by it. So to start with, I want to just share this information, and I'm not going to kind of read through all of this, but I want this to kind of be on the record as some language that we would need to know and can use when we're dealing with clients who are living with HIV or affected by HIV. There are a lot of HIV specific language that's really important to note, and I've listed some of it now. There are lots of acronyms that are used in the HIV world. And so people will talk about HIV, AIDS, ART, PrEP, PEP, right? All of these acronyms get tossed around. And so I've provided some definitions of what these terms mean so that you'll have the language that's specific to this particular illness. And again, there's a lot of language, and I've tried to make it accessible and really kind of easy to understand because you often will hear it. A couple of these that I want to point out are ones that are going to be really important if we're talking about HIV prevention or treatment and supporting clients in either of those ways. And one is ART, or antiretroviral therapy, and that is the treatment that is most common for HIV currently. And ART is kind of a broad term that's used for a lot of different medications that individuals might take. But the key thing to know as a mental health professional is that if an individual has an HIV diagnosis, we want them to be adherent to antiretroviral therapy, whatever that medication may be. And so having conversations about ART, making sure they know what it is, make sure they know what their medication is, are going to be really important in the counseling environment. The other one I want to point out is PrEP, or pre-exposure prophylaxis. And PrEP is a really important piece for HIV prevention. PrEP refers to a pill that can be taken once a day that reduces an individual's risk of contracting HIV. It's very similar to like birth control pills in that it works in terms of like a preventive effect, but has to be taken daily. People have to be adherent to that. Or else it loses its effectiveness in terms of preventing HIV transmission. All of the studies have indicated that like PrEP can be effective like in the upper 90% when people are using it the way that is prescribed to be used. There's also PEP, which is similar to like the morning after pill. It's kind of an emergency treatment. So if an individual is concerned that they have been exposed to HIV, they can take PEP within 24 hours, and that's actually the antiretroviral therapy. They can take it within 24 hours of possible exposure, and it will prevent them from contracting the virus if they think they have been exposed. So those are ones that I'll point out because they're important language to know if we're trying to really talk with clients about their experiences. I also want to note that, again, we're talking about using our voices and speaking. Language is very powerful. And so it's important for us as mental health professionals to be sure that we're using the proper or appropriate language when we're talking about HIV so that we don't further stigmatize the illness or people who are living with it. So for instance, instead of talking about HIV infections, using diagnoses or transmissions, talking about contracting HIV or transmitting HIV versus infecting someone with HIV is better language to use because it is less stigmatizing. It's also better to use like person first language when we're talking about people living with HIV and focus on the people part as well as on the living part, because we know that people can live long, healthy lives with this particular illness. It's also important when we're talking about prevention to think about how we're talking about it. So people often talk about have safe sex and protected sex. But what that language does is unintentionally, it communicates danger around sex and sex with particular people. So to kind of remove the idea that we're talking about a dangerous sexual experience, we can talk about prevention. We can talk about sex with condoms or condomless sex versus unprotected sex. We also know that because HIV is transmitted by shared needles, that the language that we use there is important as well. So in the past, people have talked about individuals contracting HIV from a dirty needle. That, of course, communicates something about people who are injecting drugs that we don't necessarily want to communicate. So if we talk about contracting HIV through intravenous drug use, we can talk about shared needles and shared works. That doesn't communicate the same sort of judgment that dirty needle might communicate. There's also this language of full-blown AIDS that has been a part of the vernacular related to HIV for quite some time. However, medical professionals do not use this language. They may give someone an AIDS diagnosis, but they don't use full-blown AIDS. It's not even a medical term. And the use of this term again, connotes fear, connotes kind of danger, and conjures up images from the 1980s that for many people are very horrific. So if we move away from that language, we can talk about an AIDS diagnosis for what it is, instead of bringing in some extra imagery that has a negative effect for individuals. Also, if an individual does succumb to this particular illness, they didn't die from AIDS, because AIDS is not something that a person sort of dies from. They may pass away from AIDS-related illnesses, which is much more accurate. For instance, if a person gets to the point where their immune system is so weakened that they can be susceptible to any opportunistic infection, they might pass away from related cancer, they could pass away from pneumonia, a number of other things could actually cause their death, and they might be associated with AIDS, but people don't actually die from AIDS. It's also important to recognize that if someone shares their HIV status, if they are courageous enough to share that they've been diagnosed with HIV, asking them how did they get it is not the correct approach. We want to know how they're doing. We want to know if they're in care. We want to know how we can support them in order to get into care and to get the help that they need. So start with the language, making sure we're using the appropriate language when we're speaking and using some non-stigmatizing language as well. And then when we're in the counseling space, when we're in our groove, doing what we do as helping professionals, it's really important for us to create a space that is sacred. So I like to use the word sacred because I think it goes beyond when we talk about safe space, right? So we talk about safe spaces a lot, And I think sacred is really more accurate in terms of what we're trying to create. We're trying to create an environment where people know that they are valued, they feel that they are accepted and loved in that area, and everything that they bring into that space matters and is valuable. And sometimes it may not feel safe because we might feel very vulnerable in that area, but we know that the space is sacred. And as mental health professionals, it's really our duty to create that sacred space where people might be nervous, people might feel vulnerable, people may feel afraid, but they know that when they come into that environment, they are loved, they are embraced, and everything that happens there is sacred and meaningful. We, of course, can do that in multiple ways. The first thing that we have to do in order to do this is to recognize that we may have some biases, and we've got to disrupt those biases. So engaging in that reflective practice is going to be critical. What do we already think about HIV? What do we think about people who live with HIV? What assumptions might we have? And how might we dismantle those biases that we hold so that we can create this safe space or sacred space for people? Yes.
Dr. Joe, sorry to interrupt. We have a question. So is it a best practice to never ask the source of their HIV/AIDS status, or to allow them to tell you whenever?
That's a really great question. So the question about like how you contracted HIV can communicate a lot of judgment. And so we don't want to lead with that. That may come up in conversation, and clients may want to talk about that. But we don't want to lead with that question because we don't want to communicate that we're judging people. We also want to recognize that for that individual, how they contracted HIV might not be the thing that they want to talk about. They may want or need to talk about the feelings and emotions that they currently have at the moment, how to get connected to care, how to get what they need. So the important thing is to see what the client needs at the moment, instead of trying to kind of meet our curiosity about what their experience might be. Now, we might know that the conversation may come up at some point about how an individual contracted HIV, and there might be some things to really dissect and process in that particular space. However, that's not a question that we want to lead with. Was there any other question? Because that was a really good one.
Nope, but we do have a few comments about how enlightening your comments on non-stigmatizing language have been. Thank you.
Oh, good, yes. And I think language is critical. Like, language matters so much. And when we're thinking about HIV, language really matters because there's so many messages that we can communicate with our language on multiple levels, and they can either dismantle stigma or reinforce it. So in our space, we've got to, again, using that non-stigmatizing language, and then of course going back to the basics of our profession and communicating with that language, empathy, genuine, unconditional positive regard. We know that that's the core of what we do. And given that there is so much stigma associated with HIV, the unconditional positive regard is critical because we may be dealing with people who already feel judged, who blame themselves for their experiences, who may be dealing with that low self-esteem. And so knowing that they come into this sacred space and are accepted for who they are, however they come into that space, and that we're able to communicate that sense of empathy, understanding, and a real genuine concern from them is going to be so important. So before we even get to doing all of the techniques that we know how to do, we have to, in this sacred environment, really prioritize those core conditions that Rogers talked about. So showing that empathy, taking the time to reflect, taking the time to explore meaning, taking the time to communicate that non-judgment to people is going to be critical before we think we're going to do anything with those individuals. Once we have done that, we've reflected on kind of who we are, what biases we might have, and we've dismantled those. We've communicated empathy, unconditional positive regard in our sacred space. Then we can move into some treatment approaches that can be really helpful for individuals living with HIV. And it's really important that we focus on the appropriate theoretical approaches because there are some that may be less helpful than others if we think about them from a theoretical perspective. So we know, of course, that CBT is very popular, and it's a useful theory. However, some of the ideas, the philosophical ideas with CBT might communicate to people that, you know, their feelings are not valid. It may invalidate the sense related to blame, related to self-worth. It might also invalidate some of their experiences related to stigma. And so we might not want to use that particular approach, and we want to use one that really centers people's experiences and from a very humanistic perspective, allows people to name things in their life what they are and work with them from those places. So some of the theories that or approaches that might be really helpful are ones that do that. So relational cultural theory, it centers the individual, it centers their cultural experiences that, as we know, are really important, especially for people of color affected by HIV. And it also focuses on how marginalization can disconnect people from other people and how that chronic disconnection impacts our mental health. So coming from a relational cultural perspective, an individual can engage with clients to kind of promote some connection, to address that sense of being disconnected from other people that causes individuals with HIV to kind of collapse in on themselves. So as I said before, that social support is really critical, and relational cultural theory really prioritizes that because it emphasizes that connection. Narrative theory can also be very helpful for individuals living with HIV. It externalizes the problem. It also helps individuals to write a story and rewrite stories about their life experiences. So there's a story related to HIV and lots of stories that might kind of globally exist about people who are living with this illness. Narrative theory really gives clients the opportunity to kind of take control of that and rename some things and rewrite a story in a much more empowering way. And then motivational interviewing, again, from a very humanistic perspective, can be used to help with a number of things. It can be used for treatment adherence. So for people who are living with HIV, it can help explore what might be some roadblocks that are preventing them from being adherent to their HIV medications. It can also be used related to other behaviors. So if people are engaging in behaviors that might put them at risk for HIV, motivational interviewing can be used to explore that and to kind of get people to a place where they're ready to make some decisions to do something very different about their lives. So that could be choices about specific prevention methods for HIV or behaviors that they're engaging in that they might want to change in their life. So within our counseling space, we can use our voice very powerfully. We can use our voice to communicate the sacredness of the space, the unconditional positive regard and lack of judgment. And we can use our voice through these theoretical approaches to best support our clients as they move towards the goals that they set for themselves.
Hey, Dr. Joe, we have a few questions in regards to some of the comments that you've just made. So I'm going to start with Eric Harlan. He asked, his experience during intake is if he asked about medical issues and a person may say no, but once asked about HIV or AIDS, then they'll say yes. How should HIV AIDS be looked at, medical, non-medical, as far as intake and diagnosis?
So I think that's a very interesting question. And so if I'm understanding correctly, there's an individual who was asked about medical conditions and they said that they didn't have any, but they did acknowledge having HIV. And I wonder if that is related to stigma. It certainly is a medical condition. However, it may not be a medical condition that an individual, when asked sort of broadly, is going to acknowledge. So it sounds like in that case, it was asked very specifically about HIV, and then a person did acknowledge it in that case. But that seems to be an example of kind of how stigma operates. We know that in medical spaces, individuals who might be interested in, for instance, HIV testing or something related to that might come in and say, well, I need to get my blood pressure checked, or I need to get my cholesterol checked. And so there's kind of a distraction related to that. And so I wonder if an individual not identifying initially that HIV as an illness that they're experiencing is related to that stigma and not necessarily wanting to acknowledge that on an intake. I don't know if asking about HIV on an intake is a great idea. I think that the context is going to matter. So if an individual has been diagnosed with HIV and there's an attempt to connect them with a mental health professional, it seems like there should be kind of a conversation on the front end with the client about what that conversation might look like. Because for an individual to go in for mental health counseling and be asked about their HIV status could be off-putting. So I think that the way that conversation happens can be a little bit tricky. Did that answer the question?
I'm looking at another question, kind of follow up with that, is when they do say yes, should it be treated just like diabetes and moving forward, or should we take a moment to talk specifically about HIV and AIDS status?
Right. So a follow-up question to that could be, like, if an individual discloses their status, a follow-up question could be something related to kind of the knowledge that we have that HIV can affect, mental health and wellness. Is that something that you'd like to talk about more? For some people who are living with HIV, they really don't want to, that's not their concern. They may have something else that they want to talk about. They may not want to kind of explore that particular issue. But for some people, it absolutely is what they want to talk about. And so really, it's just a matter of asking, is this something that you would want to discuss or feel comfortable exploring more?
Thank you for that. Another question, the questions have been really coming in. How do you handle an issue of privacy and confidentiality when an HIV positive client is flirting with innocent girls?
So I wrote an article about this, about the ethics related to HIV, because this has been something that in the 80s and 90s, there was a lot of things written in the counseling literature about confidentiality and HIV, and we haven't really revisited that. So here's the thing. We know that confidentiality is the cornerstone of what we do. If clients don't feel that they can share and that trust that that information is going to be held private, they're not going to share. And then there's no purpose in having counseling. So we know that that is critical. We also know that our ethical code, the ACA code, has a standard about contagious, life-threatening diseases. The article that I wrote challenges that particular standard, because what that standard says is that, of course, we uphold confidentiality. However, if an individual has a contagious or life-threatening disease, that we might be justified in disclosing that information to an identified third party. So it doesn't give us a duty to tell a third party. We do not have a duty to tell a third party if an individual is living with HIV. We do not have a duty, period. What it suggests, however, is that we might be justified if we breach confidentiality. And so the article that I wrote challenges that, that we've got to really think about what the implications might be and all of the information that we would need to know to really ethically make that decision. And there's just a lot of things that we don't know that we should not assume. Again, going back to like HIV criminalization laws, we shouldn't assume that an individual is going to be a threat to another person. And so we have to be very careful about that. So in that instance, if I have a client who is, flirting with people, and it doesn't matter to me if they're what their sex or gender is or what their age is, my conversation to that person might just kind of be about decisions that they make regarding their sexuality. So a person living with HIV doesn't all of a sudden no longer want to be sexual. It's not that they no longer want to engage in sexual activity. They actually do. We know that sexual wellness is an important part of who we are. And so the conversation might be about that client's sexual wellness and what that is going to look like for them, how they're going to navigate interactions with other people, how they're going to take care of themselves, and how are they going to disclose their status to other people when they feel that it's appropriate. That's the conversation to have with a client. It's not to necessarily admonish them for flirting with another person, but have a conversation with them them about how they're going to kind of responsibly live out their sexual life, because they're going to live out their sexual life. So how they do it is going to be critical. So on this particular slide right here, like these are all of the things that could be broached in the conversation with that particular client. So talking with them about their sexuality and about that element of who they are, about ideas that they might have about sexuality that are rooted in culture and race and those sort of things, what prevention methods they might want to use, how they're going to disclose, like if they're adherent to their medication. All of those are conversations to have with an individual. But broaching or breaching their confidentiality to disclose their status to another person is not the route that we want to take. In some cases, that's a legal issue, but it's certainly an ethical issue as well for us. I hope that answered that question.
Thank you for that.
Okay.
We would like to know if we can have access to your slides.
Absolutely. Yes, absolutely. Yes. I can send like a PDF version of it for you as well.
Really
so
appreciate
looking at the time, do you want me, I have a couple more things to say, or how would you like us to proceed?
I'd love for you to finish up. Attendees, I'll go ahead and post the link to the post survey. And if you guys have to leave right now, your hour has been fulfilled. But I think this is a wonderful conversation, and I would love to hear more about how we can do our diligence in treating clients with HIV.
Mm-hmm. So really, I just have a couple of more things to say for those who have time and want to hold on. But again, like broaching these uncomfortable topics in our counseling session is really important. And we very much have a responsibility to be able to have open conversations about sex and sexuality that aren't judgmental, to talk about the use of drugs that's not judgmental, but that's really open, and to engage our clients in conversations about how they want to live their lives well. So how do they want to engage in prevention? How do they want to maintain their adherence to their medication so that they can live a happy, whole, healthy life? And so we've got to be really kind of open to broaching those things, using our voices and really thinking about how we formulate our questions, again, with the non-stigmatizing language, with the kind of HIV specific language as well, to engage in their conversations about what their life is going to look like now that they have been diagnosed with HIV. And the last way that I want to talk about for us to really kind of use our voices is with advocacy. And when we hear advocacy, oftentimes we think that advocacy looks a particular way and we have to do a certain thing in order to advocate as it relates to our clients. But really, advocacy can come in a variety of forms, but it is critical for us to use our voice as we're advocating for other people. First, using our voice with our clients and empowering them to advocate for themselves. That's probably the most important kind of advocacy, because an individual who's living with HIV, again, because of the stigma, as I mentioned before, may feel disadvantaged, may have kind of more barriers in their way, and may not feel like they have a voice. And so if we can support them and empower them to speak their truth, to advocate for themselves in medical settings, to advocate for themselves in their families and in their communities, that's going to be a critical part of this advocacy. So if we can do that within our counseling space, we've done a great deal. And we've been able to really use our voices to make a change related to HIV stigma. We can also advocate on other levels. So if we think about on kind of an institutional level, there may be policies in place that adversely affect people who are living with HIV. And so we might advocate on behalf of our clients. We of course want to do this within our ethical code. So we want to make sure we have consent from our clients to advocate on their behalf. So sometimes we advocate with our clients and empowering them, and sometimes we've got to use our power to advocate on their behalf. But it's important to make sure that we get their consent to do that so we don't break that confidentiality and inadvertently disclose their status to other people that they did not want their status to be disclosed to. Advocacy can also look like working with HIV serving organizations in the area. Wherever you live, there may be organizations who serve individuals living with HIV, and engaging with those organizations to doing some awareness raising in your community, in your agency. All of those things reduce stigma, because the more that people are aware of HIV, the more that they know about it, the less stigmatizing beliefs they're going to hold about the illness, which means that your clients will have a more positive experience. And finally, once we get kind of on that larger scale, that political advocacy is going to be critical. Anything related to healthcare is going to affect individuals living with HIV. So as we've seen over the past few years, that the Affordable Care Act has been affected in a number of ways. That's really critical for people living with HIV, because the Affordable Care Act ensures that individuals with pre-existing conditions have access to health care, which HIV is one of those pre-existing conditions. The Affordable Care Act also provides for a number of prevention methods related to HIV, as well as treatment. And so it's really important when we think about access to health care that for HIV prevention and treatment, it's critical. So to advocate to ensure that those things stay in place is a way that we can use our voice as mental health professionals. And then, as I mentioned before, the HIV criminalization laws, the reformation of those laws is critical, and we might advocate on the state level for state legislators to address those laws so that they are not based on outdated science and don't further stigmatize people living with HIV. So to kind of wrap us up, I want to bring us back to Audre Lorde, who said, "Your silence will not protect you." And I think this is critical for us to remember that, you know, stigma can cause us to not speak, but it's really important that we do speak. It's better for us to speak. It's better for our clients to speak so that we can address the stigma that is impacting them and that they can live full, happy lives. So I'll stop there. I do want to share that on these slides, I do have some resources here. Some of them are the articles that I've referred to in this webinar, but there are also some links to some websites that have really good information that can be helpful just to learning the basics about HIV, and also looking to see what is being done about HIV in the Black community as well as in the South. And there's my contact information. So I'll wrap it up there. And if there's any lingering questions, I'm happy to take them.
If you have a question, you can just go ahead and raise your hand and I will allow you the opportunity to speak with Dr. Joe. Okay, we have a question. Patty, I'm gonna unmute you and you can talk.
I just wanted to find out whether it's from Doctor or from you, Shanice, how we might be able to access the slides after the presentation is over.
I'll send them to you in an email.
Great, thank you.
Mm-hmm. Other questions? All right, well then, I want to thank you all for attending our final minority mental health webinar today. We're so excited. Thank you, Dr. Joe, for this delightful and informative presentation on how we can do our part to create sacred spaces. Want to remind everyone to please be sure to fill out the eval form so that we can continue to host these wonderful webinars throughout the year. Please be on the lookout for future announcements. We do have our call for proposals out, so we're looking for more presenters, more topics for the rest of the year. I hope you have a great afternoon, and we look forward to seeing you in the future.
Thanks, everyone.